back to our series Remote Dermatology, and it's my pleasure today to work with Bolu Ogunyemi from Newfoundland. Welcome. Nice to see you.
Thanks for having me.
Yeah, so I'd just like to start by asking you to just introduce yourself, where you work, where you practice, and how long you've been in this community.
Sure, my name is Bolu Ogunyemi. I'm a medical dermatologist. I work in my hometown of St. John's, Newfoundland, Labrador. I've been working here since 2018, and I do a lot of work in Labrador City. So I've actually been going there since only a few weeks after I began practicing as a staff dermatology. I service Labrador regularly, see patients from other neighboring communities, including Churchill Falls, and even from Quebec, because Labrador City is right at the border of Quebec. So I see a number of patients from Quebec as well.
Oh, interesting. I didn't know that. Bolu, what factors led you to offer this sort of rural outreach program rather than just focusing on a, central practice?
Well, I've always felt that health equity is important, and the inequities faced by folks that live in rural and remote areas are pretty clear. They've been evident since the beginning of my medical career. So it's nice to be able to contribute and narrow some of the gaps by regular outreach clinics. And it's especially important because now that we can leverage virtual care. So now, though I've been offering virtual care before the pandemic, folks are more comfortable now, and there's a little bit more infrastructure. So now it's important to be able to leverage and integrate that into the overall care of patients in rural and remote settings.
Mm. Well, for you, what is unique about working in a rural community, and what supports are in place? What's different and unique to patient care in these areas compared to in St. John?
You know what? I find a little bit more generalism is needed and encouraged in rural and remote areas, where some cases I might refer to another specialist in St. John's, where there are many specialists around. In Labrador City, you do bigger cases for surgery. You might do more management of patients with rheumatologic and dermatologic overlap conditions. So it kind of expands your scope of both, I would say, medical and procedural dermatology. So that would be one important and I find actually very, very valuable change in terms of widening the scope of your day-to-day practice.
Hmm. What are the rewarding pieces for you for working in these communities?
Well, I find the patients are very grateful because it certainly is important to meet people where they are and deliver care where people live, work, and play. So it's an honor to be able to do that. And it feels nice to know that you're helping patients, especially in a time where traveling can be very difficult, both in terms of travel time, time off work, and certainly even safety of travel is a consideration, in my province. So to be able to alleviate patients of those burdens, during my clinical work is really great to do.
For sure. So the flip side of that coin is, what are the unique challenges that you face when you work in these outreach communities?
So, I mean, a big one, as you mentioned, would be lack of coordinated care in some cases. So there's many services, whether subspecialty human resources in terms of specialists or even subspecialty services that are not available there. For example, phototherapy is not available at this present time in Labrador, although it is available in many rural and remote areas of the province, as well as specialized wound care clinics or patch testing. So there are so many services that some folks would have to travel to the island portion or maybe even St. John's to be able to access to have the same level of care as they would if they lived in and around St. John's. So there are some challenges there, unfortunately.
Mm. So how do you manage these very complex cases when you're either traveling, from afar, or even when you're trying to, bridge the remote teledermatology gap? How do you deal with those very complex cases when you have to deal with that?
Yeah, well, a lot of it's communication. I think it's important to consider complexity, both in terms of medical complexity and social complexity. So I have a excellent working relationship with the staff at the Labrador West Health Center, which is the hospital that I work at, in terms of some of the tools I would need there. As I mentioned, that I may not need in St. John's, because the scope is a little bit broader there in terms of the procedural tools as well. Because there are some base patients that need to come to St. John's, it's important to coordinate care so that they might see the specialist, they do the consult and do the procedure all on the one visit rather than back and forth and back and forth. So that takes a lot of coordination. So a lot of, for example, taking high resolution imaging, kind of training some of the staff in Labrador, the primary care staff, that they can manage complications of surgery to minimize the amount of time the patient has to spend away from their home and in larger centers. So there's a lot of education, a lot of collaboration. Everyone needs to be on board. So I think those are some keys to be able to effectively deliver care in some of these settings.
I keep hearing that the relationships that you build in these teams, especially if they have longevity, it makes such a difference to the outcomes for these patients, and that takes time, right, to create those teams. And again, the training that you need to help them help you, has to stick and be carried forward with the right people. So yeah.
For sure.
What supports do you feel are lacking in your work that you think could be developed better?
I think it would be good to have more formal, kind of formal opportunities to have folks to, yeah, so folks from different, with different specialist training to be able to formally have, yeah, training for primary care providers. For example, if there was a dedicated program where we could teach them how to do simple procedures and sutures, etc. I mean, I do quite a bit of teaching when I'm there, but it's more didactic teaching. Whereas I think a lot of the times it's the hands-on that folks really need to be comfortable with. So if there was kind of a more formalized setting for that to happen, I think that would be useful, like small groups, small group session, but applied to continuing medical education. So
Mhm.
yeah, so I think that would be something that's useful. I think overall coordination is key as well. So there's a number of sites where the local health authority or community is really proactive in having dermatologists to work in those centers. But there are other sites in the province that have a larger population that, for whatever reason, we just can't provide care to those areas due to infrastructure and other issues. So it would be great to have a coordination of some of these efforts so that things that are done well we can duplicate in other centers to make sure that folks all over our province have equitable access to dermatologic care.
Yeah, you don't want to reinvent the wheel every time. And yeah, when something's working well, yeah, try to
That's right.
transplant it. So, what sort of incentives do you think draw people to doing this kind of work?
I think it's good to have a change in pace. If you're doing the same thing day in, day out for decades, I think some people find that that can be challenging in a way. So it's important to, number one, have a change of pace. Number two, as I mentioned, the scope of practice is a little bit broader, so that can be useful as well. And I think it can often be an eye-opening experience of rural life, rural practice, and really elements of the human condition that one can't see in a larger center. So, for example, I've done a number of clinics on indigenous reserves that are fly-in only. So you can't access these communities besides, flying in a very, very tiny rickety plane. So as you can imagine, serving a community of, 500 to 900 people, you learn a lot about the way people live currently, the way people have lived since time immemorial, because these are indigenous communities, and it really, broadens your perspective, not just as a physician or a dermatologist, but really as a person and as a Canadian and a settler on this land.
I love that. It sounds like one of your values is just having that connectivity and that variety just brings a lot to your practice and your career. That's, yeah, that's inspiring. So what advice would you give dermatology residents if they were to be considering setting up a practice in a more rural area or even a remote area?
So I think some important things would be, again, scope of practice. Um, and it's advice that was told to me when I was going through dermatology training. I also went through UBC, especially in your, in your more senior years, where some folks are, the exam is very stressful, but you really need to take advantage of, as much clinical opportunity and exposure as you can, both in urban and in rural settings. Both in terms of procedural care or advanced therapeutics, or really getting the details of managing social aspects of care, or some care that other health professionals would do. For example, wound care. It's not enough to choose the type of wound. Like, you need to be putting, you need yourself be putting the wounds on these patients, because in rural areas, there's not a specialized wound care clinic with 8 nurses. It's you and the patient. So those are some things that I think dermatology trainees can really try to master, so that when it's just them in these communities, then they feel more comfortable.
Mhm. Well, so true. So, how do you think the CDA, as an organization, as an association, could better support some of this rural and remote work of dermatology that's happening in the corners of Canada?
Well, I mean, I think this is a good start, certainly by showcasing the benefits and the challenges of this work, and making the information available to residents so that they consider it as part of their career. As I mentioned, I started working in October, and in November I was already doing rural clinics in Labrador. So for me, it's naturally been part of my career as a staff physician. So I think this is an excellent start. As I mentioned, if it's possible for the CDA to collaborate, possibly either with the Royal College and or the Canadian College of Family Physicians, about more didactic, hands-on training opportunities that might be useful. Because I know there are a number of Royal College opportunities, but they're more or less specific for Royal College members, which of course don't include family physicians, who are providing most dermatologic care in Canada, number one, and particularly in rural and remote areas. So that'll require some collaboration between these bodies, where there are currently some silos. So that's an opportunity for the CDA to take part.
Yeah, we can really lean into our educational offerings for sure to help those primary care doctors who really want that work. Yeah. Well, this is great. Thank you so much, Bolu. It really is such an interesting snapshot. I could probably ask you another half hour worth of questions, and you probably have lots of stories about what it's like working in an area of the country that most of us never get to see. So really interesting career, I'm sure.
For sure. And then, yeah, the last point I just wanted to make was, really, I could only avail of this opportunity based off of the work of those that came before me. So Dr. Ian Landells, Dr. Wayne Gulliver, Dr. Syed Pirzada, Dr. Kamal Osin, Jay Coffey, have been contributing to rural care, among others, including Dr. Ananda Krishnan, for many, many, many years in our home province. So, I really stand on their shoulders in order to, continue delivering equitable care to folks all over our province.
Yeah, so true. Amazing. And what a great legacy of people you have in Newfoundland. That's amazing. Quite a list. Well, thank you so much for your time.